Thank you, Nathan and Michelle. Trick this again. This is a deja vu. It's not a debate because I know I'm going to win every time. It doesn't go. Michelle, do not allow my slides to go.
There you go.
Okay. Those are my disclosures.
You can put it on the light, así para que
The
se-
lighting.
Yeah.
Well, those are the procedures quotes available. The gastric bypass, then the sleeve gastrectomy, and the DS or the BPD Scopinero style. Well, as the panel gave it 10 minutes, 11 minutes, I'm going to focus on 5 facts and 1 myth. No cambio. It's not changing. Okay.
There you go.
Well, the BPDS, I think it's the best procedure available for metabolic and bariatric surgery. Meta-analysis, case series, etc. But there are some long-term severe complications, lots of revisions, malnutrition, diarrhea, intense micronutrient deficiencies, hepatic disease and liver transplantation, etc. So it's the best, and one very nice meta-analysis proved that if we got a small trend to better weight loss in the DS group, although it was very reduced, and the improvement of the cardiovascular risk factors are the same within the gastric bypass and the DS, why the hell should I go for a more difficult operation and that delivers the same outcomes long term? Well, fact number 1, weight loss is far better with gastric bypass than sleeve gastrectomy. This is a very nice paper that it's online from the early March, where we can see here that the Roux-en-Y gastric bypass at 1 year, so short term, delivers much better results regarding BMI decrease than the sleeve gastrectomy. If you look at the Cleveland Clinic series on diabetes, if it's improved or cured codes, comparing some operations like adjustable gastric banding, the sleeve gastrectomy, and the Roux-en-Y gastric bypass with at least 6 years of follow-up, we can notice there in the red square that the sleeve and the band are siblings. They do not promote long-term weight loss, while the Roux-en-Y gastric bypass keeps its weight down. This is a paper by a randomized control trial by the Maresco group from Strasbourg that compare the gastric bypass versus the sleeve gastrectomy. Look at how nice the statistical difference between, in a randomized control trial, weight loss favoring the gastric bypass. This is an IFSO register, the European chapter. In all time points of follow-up, the Roux-en-Y gastric bypass delivers better weight loss than the sleeve gastrectomy, again repeating the randomized control trial studies. This is a very interesting paper published a couple of years ago by the group from Barcelona. The first author is an endocrinologist called Josep Vidal, and he split his outcomes into good weight loss, secondary poor weight loss failure. It means patients recur obesity after 2 to 3 years post-op, and primary failure, it's patients do not lose over 10% of total body weight loss within the first 24 months. And he tried to find who's the culprit of which is the most important thing to sustain weight loss. And he found that sleeve gastrectomy by itself is an independent predictor of secondary weight loss failure. Well, this group used to do 100% of sleeves. Well, they don't do that anymore after their own trial. So fact number 1, weight loss is much better with the sleeve, with the bypass. Fact number 2, gastric bypass resolves GERD. Sleeve gastrectomy causes it. Well, this is a very nice review published on Nature Reviews Gastroenterology in 2015, where we can see that 88% of GERDs are solved in this review after a Roux-en-Y gastric bypass. It's different than the 2 siblings, the gastric banding and the sleeve gastrectomy, what I like to call a turbo band. They got the same outcomes regarding the presence of GERD. This is another randomized control trial published by Marco Buder's group from Switzerland, where again they analyze GERD and look at the results of GERD. We have de novo GERD, we have worsening of a GERD, and this is very bad. If you compare to the gastric bypass, we have similar remission rates, but very, 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 very small de novo GERDs or worsening of the previous situation. This is another paper that came from a very enthusiastic group that we used to do 100% of sleeve, and they are moderating their enthusiasm of sleeve gastrectomy. 40% of de novo GERD. So it doesn't solve, it solves reasonable numbers, but 40% of de novo GERD is not that nice for our patients. And if you look at Barrett's esophagus, within 5 years follow-up, there's 17% of Barrett's esophagus with no relation to the symptoms. So we're condemning patients to Barrett's esophagus with an operation that delivers less weight loss, and you'll see less metabolic outcomes. Fact 3, Roux-en-Y gastric bypass has far better type 2 diabetes and metabolic syndrome outcomes. This is again from the Sudan paper. John Morton's is the senior author. If we compare what's in green yellowish there, the Roux-en-Y gastric bypass exceeds diabetes control, musculoskeletal diseases, sleep apnea, GERD, etc. Again, regarding diabetes and the sleeve gastrectomy loses by far to the gastric bypass. Again, let's get back to the Cleveland Clinic data. If you look at the long-term A1C changes, we compare the gastric bending, the laparoscopic sleeve gastrectomy, and the Roux-en-Y gastric bypass with long-term follow-up. Well, again, there is absolutely no patients with A1C below 7 in the sleeve gastrectomy group, while most of the patients in the Roux-en-Y gastric bypass taking less medication than the two other groups, they have a much better metabolic control long-term. This is a randomized control trial between the laparoscopic sleeve gastrectomy and the mini gastric bypass in lower BMIs. At the same weight loss, diabetes resolution is much, much better following a food diverting operation. This is getting back to Marco Buter's study published in the Annals of Surgery. Look at the numbers regarding diabetes resolution in the sleeves versus the bypass. Most of the sleeve gastrectomy patients at 3 years had A1C over 6.5% and 2 times more medication than the bypass group. This is Phil Showers, published in mid-February this year, the 5-year Stampede outcomes. Although it was not powered to measure differences between the gastric bypass and the sleeve gastrectomy, both of the operations were better than the best medical treatment available, but the use of cardiovascular and glucose-lowering medications, including insulin at 5 years, was significantly reduced from baseline, mainly in the Roux-en-Y gastric bypass. Roux-en-Y gastric bypass patients use 4 times less medication to achieve the same control. For the sake of time, I cannot undergo with different explanations. Well, I saw this Jack Himpen's paper, and I see, well, 11 years follow-up, probably they have very smart tips to give us regarding the sleeve and diabetes. Well, no diabetes outcomes. He was really smart. He excluded metabolic patients to the sleeve group. So he was really much more smarter than I was. That's a fact. Fact number 4, when you convert into Roux-en-Y gastric bypass, it helps the bad outcomes, and a lot. Jack Himpen's data, 32% of a conversion to Roux-en-Y gastric bypass with better weight loss after conversion. Here in the moderating enthusiastic group of the sleeve gastrectomy, 19% of a conversion for insufficient weight loss, good weight loss after the conversion, 2 years follow-up. And the facts are there. The myth is the sleeve, it's easier and safer. Well, I'm not a bad surgeon. I don't think it's easier and safer. But let's see what Kotari means with his meta-analysis and systematic review comparing thousands of patients between the Roux-en-Y gastric bypass and the sleeve gastrectomy. What we can see here, it's very interesting. Leaks and mortality, it's exactly the same. There's no difference. So it's not easier or more complex. It's actually based on sleeve size, it's based on bougies, it's based on several. Maybe there's a mechanism that undergoes with the bile acids, but we need to study this, and I know people who are doing this with they're skilled for basic science, and I'm not. Well, this table really puzzles me. If you ask me, in my country, Brazil is the second largest volume of bariatric surgery in the world. We'll still have the gastric bypass as the most performed operations. Although the sleeves raised a little bit, we still have the gastric bypass as the number 1 operation. And this thing really, really puzzles me. This is the last slide. Look at the numbers of growing numbers from 2011 until 2015. And I believe in this country, within 2-3 years, revisional surgery will be the most performed operation, because there is a direct relationship between the increase of sleeve gastrectomies and the increase of reoperation. So I have an Uber fact on why gastric bypass is the best metabolic procedure available so far. No questions, no debates. Thank you.
Thank you, Ricardo.